Okay.
Bismillah ar-Rahman ar-Rahim. Welcome in this new meeting of Egyptian Society of Nephrology and Transplantation online CME meetings. Today, we are to start in a pathology session with Professor Anjali Satoskar from Ohio State Medical University Center Pathology Lab, Director of Pathology Lab from USA, which will address in a case interaction, in a case-based way, method interaction way with an important topic. We have two moderators, Professor Dawla Bilal, Professor of Nephrology and Internal Medicine, Cairo University. She is the past president of Cairo Asr Al-Aini Nephrology and Transplantation Dialysis Center. And now she is the head of scientific committee of Egyptian Fellowship of Ministry of Health. I'm Professor Hussam Ismail, Associate Professor of Pathology, Bani Suef University, and she is the chair of Renal Pathology Working Group in the International Society of Nephrology. I will leave them to them the floor to lead this session and introduce Professor Anjali Satoskar. Please, Professor Dawlat, take the floor.
Okay. All right. Good evening, everybody. It's my pleasure to introduce Professor Satoskar. She is a professor and director of the Nephropathology Lab at Ohio State University, Columbus. She is participating in renal pathology for the past 15 years. She attended medical school in India, and then 5 years pathology practice in the US, and then 2 years as a fellow in renal transplant pathology. She is active in clinical research and also teaching students and fellows. Her main area of research is the SARM, the Staphylococcus staph aureus related nephropathy. Although this is a little bit different from what we will hear from her tonight, but I'm sure we'll get something very rich. Especially we have another eminent pathologist with us, Professor Hussam Ismail. I'm the only one outside the group, yeah. two great pathologists and one nephrologist.
Me also,
So,
Professor Dawlat.
have a nice evening.
Thank you very much, Dr. Dawlat, and it's really a pleasure to have Anjali with us tonight, and I'm really looking forward for this presentation, which is going to be about a case-based discussion, as I understood, regarding monoclonal proliferative glomerulonephritis, or C3GN, and I think we can start right away for the sake of the time. Anjali, can we start?
Sure.
Yeah.
So thank you all for this kind introduction, and thank you, Dr. Waisam, for making this possible, coordinating. We have been discussing for many months, actually. And the aim behind doing this, at least in my mind, was not just for me to give a lecture, but to introduce our group to yours and open the doors for some exchange of information, cases, because I'm sure there are some diseases that are very unique in your part of the world and some diseases that are more common here. So some common discussions would certainly be beneficial for both sides. So that was the aim, and I have invited many of we have a big nephrology division here, and transplant division, and also nephropathology. We have 4 or 5 nephropathologists here. I've invited most of the people, but as you know, it's the middle of the day. It's many people are in their clinics and so on. So I don't know how many are here. Some of them will come. So I'll just turn off my video for now, and I will start. So I want to discuss a very interesting case, and believe me, it's a long case. It will take up 1 hour. It is a case of MPGN with changing immunofluorescence patterns on the biopsy. So this is a very mysterious disease, in my opinion, MPGN. And so it's really, I think it's a good idea to discuss it. And as I discuss the case, I will touch upon the key features in PGNMID, C3G, and related diseases, and then give you a pathologist perspective on newer antiplasma cell and complement-based therapies used in these diseases. So let's start. We had this unfortunate, we still have this patient still comes for follow-up. She was a 17-year-old white female back in 2007. She was otherwise quite healthy. And in fact, she was very active in sports. She noticed lower extremity swelling during one of her travels in early 2007. Now, lower extremity edema during travels is not a very unusual symptom. Many people get this. So for several months, I guess she was being seen on and off, but nothing was done. But then she gradually had this increasing swelling and shortness of breath. And she again presented in November of 2007. She had several repeat labs around that period, and her serum creatinine had started to increase a little bit, 0.8 to 1.1. And she did have quite a bit of protein in her urine, up to 4 grams on 24-hour collection. Her complement levels were very low, particularly C3, but even C4, both C3, C4 were low. So at that time, she underwent her first kidney biopsy, and let's look at the biopsy. This was back in 2007. It mainly showed glomerular disease. The glomeruli were enlarged, big size glomeruli. They were hypercellular. There's endocapillary and mesangial hypercellularity, thickened capillary loops, nodular accentuation. So it has this PGN pattern or membranoproliferative pattern of injury. The silver stain shows very thickened capillary loops, almost forming little spikes along the periphery. On immunofluorescence, there was IgG, quite bright, 2 to 3 plus along the capillary loops and mesangium. Not much IgA, IgM, very little. It's not totally negative, but it's much less than the IgG. C1q was also 1 plus maybe, but C3 was very bright, 3 plus. Kappa lambda, it did show lambda predominance compared to the kappa. So you have IgG, bright IgG, C3, and lambda. At that time, we did not have IgG subclass staining. This was, remember, this was back in 2007. So we could not do subclass staining at that time, but we had electron microscopy, which showed very big subendothelial electron dense immune type deposits without any substructure. There were some intramembranous deposits also, mesangial deposits, some more, the capillary loops. There was podocyte foot process effacement. This picture nicely shows the GBM duplication. Like this is the original glomerular basement membrane. And due to repeated cycles of injury and healing, which is typical of MPGN, there is a new basement membrane formation, which gives rise to this tram tracking or duplication. And then there are these electron dense immune type deposits. We also noticed a few endothelial tubulo-reticular inclusions or TRIs. And these are considered the hallmark of high interferon levels, typically seen in autoimmune disease like lupus nephritis or after viral infections. So at that time, back in 2007, we only had this classification, MPGN type 1, type 2, type 3. So the features in this biopsy, they fit with MPGN type 1. Some of the unusual features, though, were the bright IgG lambda staining along with C3 and mild staining for other immunoreactants, and then the TRIs, endothelial tubular-reticular inclusions. She's a young female, so the possibility of lupus did come up. However, she did not have any extrarenal signs of lupus, no autoimmune serology. They were all negative, ANA, double-strand DNA, etc. There was no evidence of recent bacterial infection, so this was less likely to be a bacterial infection-associated glomerulonephritis. And it didn't seem like an acute process. This was going on for several months, so most likely it was a subacute process. So she was started on a course of oral steroids and azathioprine. And she was lost to follow up for some time. Then she came back in 2013, but not at our institution, but at a different hospital for increasing proteinuria. So we don't have the slides on that biopsy, but we did manage to get the report. And the findings were quite similar. Enlarged glomeruli with MPGN pattern, not much glomerular sclerosis, no crescents. The tubular interstitium was good. There was not much fibrosis atrophy. And immunofluorescence showed similar findings, IgG C3 dominant with mild other immunoreactants. Lambda was 2+. So they almost called it a full house pattern. They did not see TRIs, but endothelial tubular reticular inclusions, they may be very few. And unless you look for them specifically, you may not see them. So anyway, they did not find them. The patient was continued on azathioprine at that point. And then she again was referred back to our institution in 2018. So remember, all this started in 2007. Now it is 2018. So now she's 28 years old. And the history that she came with is she had some form of MPGN. By now, we had a slightly better classification of MPGN, and we had started to understand more about the C3GN and C3G, C3GN, and the classification of MPGN. So it was like, does she have C3GN? Some form of MPGN. We were not sure. She was on azathioprine. Her blood pressure was well controlled. So the first thing we did, and what every pathologist should do, is go back and look at her previous biopsies. So we pulled out the biopsy from 2007, and we retrospectively stained it for IgG subclasses. And what we saw was it was IgG3 predominant. It was monotypic, means there was only one IgG subclass. So just to review, this is what her biopsy in 2007 showed: IgG dominant, strong C3, lambda dominant, and then on subclass staining, it was monotypic, IgG3. So now we had this paper. There was some literature on PGNMID, and this immunofluorescence phenotype actually matched that. So this time on this biopsy number 3, our most likely diagnosis was PGNMID, or proliferative glomerulonephritis with monoclonal IgG deposits. Some lab work was also done. Her electrolytes were fine. Her renal function was still normal. She still had very low C3 and C4. She does not have any evidence of monoclonal gammopathy. Her immunofixations were negative. Her kappa lambda ratio was also within normal limits, but she was found to have nephritic factors, C3, C5 nephritic factors. This time we also sent her workup for complement regulatory protein abnormalities. As you know, this workup is not done everywhere. There are only 2 or 3 institutions in the country that does this workup. But her workup for mutations was negative. There were no mutations in factor H, factor I, membrane cofactor protein, C3, and so on. So the main thing was complement consumption, nephritic factors, and yeah, that was about it. We did a bone marrow biopsy was done. It was negative. Her urine protein excretion, she continued to have protein excretion, and it kept oscillating and wavering. It went up and down from 30 to 200. So at that point in 2018, when she came back to us the second time, because of continued proteinuria and continued low complements, a third biopsy was done, biopsy number 3. And this is what it showed. Again, the glomeruli were really big, all of them. Same MPGN pattern, thickened basement membranes and hypercellularity, still no crescents or anything. And still the cortex was well preserved. There was not much interstitial fibrosis, tubular atrophy. Silver stain nicely shows this duplication, tram tracking of the basement membranes, suggesting that this is a prolonged injury with repeated flares and healing of the GBM. It's almost like wound healing. Immunofluorescence now, again, it showed very bright C3. IgG was still there, but the intensity seems to be going down compared to the first biopsy. And IgA, IgM again were similar, just scant staining. C1q was hardly there, it's almost negative. Kappa, lambda, it's hard to tell the difference. Maybe lambda is a little bit more, but it's just a little doubtful whether it's really monoclonal. We did the IgG subclasses this time, and again, it showed only IgG3, monotypic IgG3. So somewhat similar to the first biopsy, only thing the IgG is not as bright as before. Electron microscopy showed numerous electron-dense immune type deposits, subendothelial, lots of mesangial. This time we were also seeing a lot of subepithelial deposits, which were not seen so much in the first biopsy, but we are seeing a lot now. We did not see any endothelial TRIs this time. There's a lot of podocyte foot effacement. So just a little diversion just for the fellows and whoever, the junior people. MPGN, also called mesangial-proliferative glomerulonephritis, it's basically a chronic nephropathy, chronically relapsing and nephropathy, causing a lot of capillary wall thickening, remodeling, mesangial expansion, hypercellularity, nodular lobular appearance of the glomeruli. Previously, we just had this one classification based on the electron dense deposits on EM, MPGN type 1, type 2, type 3. But since then, we have come a long way in our understanding of this disease. And in 2013 or around 2014, this etiology classification based on immunofluorescence staining was established. And these are some of the important references from that time. So MPGN is now just considered an injury pattern. It's not a disease by itself. And it's divided into these two big umbrella terms. Either it is C3G or immune complex mediated MPGN. C3G, you can diagnose it only after you have excluded post-infectious or post-streptococcal GN, because as you know, post-streptococcal GN also has very similar findings, C3 predominant deposits, low C3 in the serum. So they have also now found antibodies to factor B, but it tends to be transient. The patient recovers on his own. But after 3 months or so, if the patient continues to have low serum complements and renal dysfunction, it's most likely C3G. And C3G can be either C3GN, where you have immune type deposits, or dense deposit disease, where you have those extremely electron dense, elongated, cylindrical, intramembranous deposits. The other type of MPGN is immune complex mediated MPGN, idiopathic immune complex MPGN, where you don't know the cause. You don't even don't have an obvious cause. And you can establish that diagnosis once you have excluded all the secondary forms of MPGN, where you have an obvious cause, such as type 2, type 3 cryoglobulinic glomerulonephritis, or lupus nephritis, or infection-associated, bacterial infection-associated, like staph or other infection-associated GN, or monoclonal gammopathy-associated kidney diseases. Now they're termed as MGRS, when you don't have an obvious lymphoma, but you still have a plasma cell clone causing glomerular injury. Well, the most prominent actor in that is PGNMID, and others include monoclonal cryoglobulins or C3GN in the elderly. Remember, this is C3GN in the elderly, this is C3GN. I'm sure it is confusing, but these are the terms that are used currently. So C3G, it's diagnosed using this definition, where C3 staining on immunofluorescence is much stronger than immunoglobulin staining, at least 2 orders of magnitude stronger. In cryoglobulinemia, you can have hyaline thrombi in the glomerular tuft. They usually stain for IgG and IgM. In these immune complex diseases, you have IgG or IgA dominant immune complex deposits along with strong C3. And in MGUS-associated diseases, you will have monoclonal light chains with or without heavy chain, monotypic heavy chain. So this group of diseases is thought to be due to dysregulated alternative complement pathway activation in the fluid phase. Here, it's it's thought to be driven by antigen antibody complexes causing classical complement pathway activation and sometimes even lectin pathway. And here it is usually driven by the paraprotein, which can get deposited and cause kidney injury, or it can indirectly cause complement activation. So this is kind of a framework. This is the classification that is currently used for diagnosis of these MPGN type cases. I've just put here two conditions which also can show MPGN pattern, like chronic thrombotic microangiopathy and transplant glomerulopathy in transplants. It's not really related to this, but the glomerular pattern or glomerular appearance can look very similar. So I don't want to go into huge details of each disease in this because I can't do that in an hour, but just a few things for the fellows. PGNMID is considered a monoclonal gammopathy associated kidney disease. Usually the patients do not have obvious lymphoma or myeloma or high tumor burden. So it is actually called MGRS or monoclonal gammopathy of renal significance. In the absence of obvious tumor. It's a relatively new term coined about 5 to 6 years ago, where you just have, instead of a tumor, you just have this monoclonal clone of B cell lineage cells, either B cells or plasma cells, which are secreting this nephrotogenic immunoglobulin components, which cause damage to the kidney, either by depositing in the kidney or indirectly through complement activation or even thrombotic microangiopathy. In some of the patients, you can actually detect this plasma cell clone using our usual routine diagnostic tests like immunofixations and free light chain assays. But in a large subset of patients, this remains undetectable. And in those cases, it's really a problem as to how the patient should be managed. And usually the phenotypic appearance in the kidney is either in the form of amyloidosis, light chain deposition disease, or PGNMID. A combination of monoclonal light chains with or without monotypic heavy chains. So this is no longer MGUS. It's not monoclonal gammopathy of unknown significance. It is monoclonal gammopathy of renal significance. And these patients do, aggressive therapy is warranted against the B cell or plasma cell clone to stop the renal injury. These are the drugs usually used, but of course there are newer and newer drugs on the horizon, and it may depend from institution to institution what drug combinations are used. C3GN, on the other hand, is a rare complement-driven glomerular disease due to uncontrolled complement alternative pathway activation in the fluid phase. On the cell surface activation is usually seen in another group of diseases, that's hemolytic uremic syndrome. You see C3 dominant immune type deposits. You may see complement consumption in the serum, little or no immunoglobulin components on immunofluorescence staining, and I already told you this is the definition that is used to diagnose C3GN, where C3 staining is 2 orders of magnitude more than immunoglobulin staining. It is a rare disease, even though as pathologists we keep seeing it. That's because we see a skewed population. We only see the cases that are biopsied. But if you consider the entire population, the prevalence is pretty low. Unfortunately, a large percentage of these patients progress to end-stage renal disease. And underlying pathogenesis, the alternate complement pathway disruption, can be due to various different genetic defects. C3 convertase, like autoantibodies to C3 convertase and C5 convertase, the nephritic factors, genetic deficiency or mutations in the complement regulatory proteins, particularly factor H, or autoantibodies to factor H. And then you have this whole family of complement factor H related proteins, which can create havoc. So this was just a little information, but we'll come back to our case now. So what does our patient have? She has a C3 dominant MPGN pattern on her biopsy with IgG3 lambda staining, nephritic factors, no monoclonal protein. And these, I've already shown her labs. We didn't find any evidence of monoclonal gammopathy. Bone marrow biopsy was negative. And I want to show this paper here. It's a very nice paper written by, I think, from the group in Mayo only, back in 2020, practical management of this group of diseases. The only way you can diagnose these diseases by ruling out what is less likely. So that's what we did. We ruled out lupus nephritis. We ruled out infection-associated glomerulonephritis. MGRS, it's difficult to rule it out because according to this first paper by Nasser et al. In this PGNMID, most of the patients do not have a detectable plasma cell clone. Only about 30% of the patients will show, will demonstrate, or they have detectable paraprotein on our routine diagnostic tests. Most of the patients don't have it, or they develop later on. So we cannot rule out PGNMID. It could be. C3GN with monoclonal gammopathy is usually described in elderly patients. So this was less likely. Our patient was very young. So either it is PGNMID or it is a C3GN with complement pathway dysregulation. So at that time, I was quite confused. So what I did was I pulled out all the biopsies that we had in our records, which were diagnosed as PGNMID or C3GN. And I sort of just looked at them for the similarities and differences to see why it is so confusing to differentiate these two. And we actually published this paper of last year. So what I found is there were similarities and differences in the biopsy, like morphology. Both of them show very frequently, or the most common pattern of injury in both of them is MPGN pattern of injury. The deposits on electron microscopy, they are also granular, non-organized electron dense. They just look like run-of-the-mill immune complex deposits. In PGNMID, you may have this variegated appearance to the deposits where you see these alternating bands of electron dense and less electron dense alternate. They look variegated, but of course it's a soft feature. Not every case will show that. C3 staining, obviously it's a defining feature of C3GN. However, in PGNMID also, you very frequently see C3 staining, and it tends to be quite bright. So this is mean C3 intensity in PGNMID and C3GN. So it's not as strong as C3GN, but it's still quite high, over 2 plus. So that is another reason for this overlap. In fact, out of the 45 cases of PGNMID, 44 did have positive C3 staining. In 20 of these 45 cases, IgG and C3 were equal in intensity. In 9 of the cases, C3 was stronger, was more prominent than IgG. And in 16 cases, IgG was stronger than C3. But stronger means the difference was not much, only 1 grade level difference. So you see why it is so difficult to differentiate these diseases. And what are the differences I found? The median patient age was quite different. PGNMID tends to be an adult onset disease. C3GN is more of either pediatric age or adolescent age, 22. And this was what I found in our cohort, but even Sami Nasser's cohort from his paper on PGNMID published in 2009, the average age of the patient was 54, very similar to what I found here. However, if you look at the age ranges, they are very broad. Again, giving a lot of possibility of overlap. So that was age. And then C1q staining tends to be weak in both of them. The intensity tends to be very low, but it is more frequent in PGNMID. 60% of the cases had some C1q staining, and only half of those, 30% had C1q staining in C3GN. But it's just, trace, really trace. Low serum C3 levels, in our cohort, they were not very uniformly measured, but in Sami Nasser's patient, 8% of the patients with PGNMID do tend to have low serum C3 levels. So they do have some evidence of C3 consumption. So again, it's an overlap. similar to C3GN patients. Nephritic factors are definitely more frequently found in C3G, C3GN. I thought they would be absent in PGNMID, but you can never say never in medicine. It's never 100%. There are definitely case reports of PGNMID describing presence of nephritic factors. So this is just a little comparison to show you the reason why on biopsy it can be so puzzling. In fact, there are papers out there describing proliferative glomerulonephritis, PGNMID in pediatric patients. And this paper by Truxell, they nicely showed this comparison, PGNMID in adult patients and PGNMID in pediatric patients below 18 years of age. And many of the things were overlapping, both had low C3, C4, etc. But the differences were in adult patients, there was more frequently evidence of paraprotein in the serum. They did not find that in the pediatric patients. In the ped patients, what they found was in triggering infection, particularly bacterial infection, was seen in 67% of the cases. And on tissue staining between kappa and lambda light chains, in adult patients, it was kappa that was way more frequent. 73% showed kappa dominant deposits. But in the pediatric patients, it was more lambda, similar to what we are seeing in our case. Ours is, I would consider a pediatric. It started when she was 17, and it does show IgG lambda staining. Unfortunately, in both groups, there is quite a high incidence of kidney failure. And in fact, it also recurs in the transplant kidney. And then that third group of diseases, which I mentioned, C3 glomerulonephritis associated with monoclonal gammopathy. So this was one of the earliest papers from the Mayo Clinic, where they checked their biopsies between 2009 2012. They did a monoclonal workup. They had 41 cases. They did a monoclonal workup on 32. 10 of them were found to have monoclonal gammopathy. So these were basically C3 dominant GN biopsies. They found monoclonal gammopathy in 10 patients. One patient actually had CLL. The median age of patients who did have an accompanying monoclonal gammopathy was 54, very similar to our PGNMID cases. And the patients that did not have monoclonal gammopathy, they tended to be younger. And the staining, IF staining showed C3 dominance. A little bit of immunoglobulin staining was there, but it was quite weak. And there was like a whole, I would say, mix. Some patients had nephritic factors, functional abnormalities in the alternative pathway. They did not really find mutations, though, in the proteins. And their mass spectrometry that they did on these cases, it showed a lot of C3, a lot of C4, but no monoclonal immunoglobulins. So even though they had a spike in the serum, they did not have monoclonal immunoglobulins in the tissue on their mass spec profiles, giving way to the idea that these paraproteins can cause injury even indirectly. Paraproteins can themselves behave as nephritic factors and trigger complement-mediated injury. So this is trying to clarify to you some of these overlapping disease conditions. So for our case, coming back to our case, we just followed this notion that this is proliferative GN with monoclonal immunoglobulin deposits, more like a MGRS. Today, if this case would have come today, I would just classify this as an immune complex MPGN. What it connotes, I don't know, but anyway, so at that time we favored an MGRS. And now I will discuss a little bit how this case was managed. So this graph is actually showing urine protein creatinine ratios. And I will, in relation to that, I will show you how she was treated. So remember, this case first came in 2007, had a first biopsy in 2007. The second biopsy at an outside institution was done 5 years later in 2013 or something. And then for the third biopsy, she came to our institution again in late 2017, beginning of 2018. And I already showed you the biopsy number 3. So after that, she had been on azathioprine before, but now that was stopped and she was put on this B-cell agent, anti-B-cell agent rituximab. She was given, I think, at least 2 or 3 infusions. The proteinuria kept like deviating. It used to come down, then go up again. So even after rituximab, her proteinuria didn't show a permanent remission. Proteinuria went up to about 2.5 grams. This was towards the end of 2018. At that point, rituximab was discontinued and she was started on this regimen with antiplasma cell agent and dexamethasone. And this is a proteasome inhibitor, plasma cell inhibitor, which was continued for 8 months. So it was started around the end of 2018 and it was continued through 2019. Let's see what happened. Proteinuria did not remit with this combination. It kept going up. It was now up to 3.5 to 4 grams again. And plus the patient started to develop some side effects like neuropathy and so on with bortezomib. So at that point, towards the end of 2019, bortezomib was stopped, and then she was started on this new anti-plasma cell agent, daratumumab, in December 2019. It's an anti-CD38 drug. I can talk about it a little later, but these are some of the important reports on this drug. This paper was actually written by Selam Almani. He's a nephrologist in our group. And daratumumab has shown favorable outcomes in previously refractory PGNMID. So that is the drug that was started. It did show a reasonably good response. Proteinuria came down to less than 1 gram. The renal function remained normal, which is a good thing. The nephritic factors that she had, C3 and C5, both of them disappeared actually after starting daratumumab. Serum complement levels did remain low for quite a while. But one new development was now for the first time, the patient began to develop a monoclonal IgG kappa spike in the serum after starting daratumumab. And her proteinuria, which was improving, intermittently went up. I think during this time, she also had an episode of COVID-19 infection, if I'm not mistaken. So whether that viral infection triggered some more inflammation and increased proteinuria, it's certainly a possibility, but it's difficult to prove. But because of the proteinuria again going up and this new spike in the serum, she underwent a 4th biopsy at that point. And let's see what that showed. So this was in 2020. Again, same thing, glomerular changes were still present, unchanged. Big glomeruli, impedient pattern, a lot of hypercellularity. Fortunately, no crescents or anything. But on immunofluorescence, to our surprise, the IgG had gone, it's disappeared. There was anyway, IgA, IgM were always weak, but IgG was no longer there. We did try staining with protease digestion to make sure these IgG deposits are not now masked, to bring unmask deposits, but it made no difference. We did not see any staining even after that. C1q was never there. C3, however, did not go away. C3 persisted and still was quite strong. And you can see nice granularity along the capillary loops. And so it doesn't look like a false positive, just non-specific trapping or anything. I think there are still deposits there. But kappa lambda, again, I did not see. Just like the IgG had disappeared, kappa lambda also showed no staining. So despite that new monoclonal IgG kappa spike in the serum, we did not see any light chain restricted staining on tissue. The subtype staining was also negative, to a surprise. On electron microscopy, there is definitely a lot of glomerular capillary wall injury, remodeling. This is the basement membrane, and there is the endothelium is over here. So there is massive subendothelial widening with electron-lucent material, mesangial cell interpositioning. Same here, which itself can cause a little bit of proteinuria. Few deposits are still there, like this one, like a subepithelial, another subepithelial. But if you remember in the first biopsy where I shown those huge subendothelial deposits, those kind of deposits, however, I did not see now. And although we don't have a very objective metric to count deposits on electron microscopy, looking overall, they seem to be fewer. And those subendothelial deposits actually seem to be disintegrating or resorbing. So there were some good things we saw in this biopsy, although the morphologic MPGN pattern was still there, C3 staining was still there, interstitial fibrosis tubule atrophy was, it's now coming along, but it's still mild. We did see a few interstitial foam cells, which suggest that she has persistent proteinuria. But some good things were kidney function was still stable. Proteinuria was now less than a gram. Her serum complement levels began to improve. C3 was now picking up. Remember, in the beginning, it was like 10 or something. It was really low. So it's a little better now. Nephritic factors had disappeared. The IgG lambda staining has disappeared. And electron-dense deposits on electron microscopy are fewer. Not gone, but they're fewer. So what was that new IgG serum spike? I'm sure you all have guessed. It came after starting daratumumab. It reached a peak of about 51 milligram per deciliter, but then it began to fall and it actually disappeared. It went away. On the repeat immunofixation, we did not find it, which is a good thing. So coming to our case, so here we did a biopsy number 4. The spike somehow disappeared, complement levels were improving. And so towards the end of 2021 or middle of 2021, daratumumab was stopped and the patient was maintained on just mycophenolate. So the question was, what was that spike? I'm sure you'll have read about this. Since nowadays we use these monoclonal antibodies for therapy, they remain in the serum and they show up on our protein electrophoresis and immunofixation assays, like false positives. This was first detected with this drug called siltuximab, or an anti-IL-6 drug, which was used for multiple myeloma. However, this drug was never FDA approved. But then in 2015, there were 2 new medications, daratumumab and elotuzumab, and even this third medication. They're all humanized monoclonal IgG kappa antibodies targeting the CD38 molecule on plasma cells. And these, they tend to hang around in the serum and get detected on our immunofixation assays, and which is a problem because current criteria for multiple myeloma remission, you have to demonstrate elimination of detectable M protein in the peripheral blood. But if these drugs show up, they can really cause a lot of anxiety, particularly if the original spike was also IgG kappa. And this is just a figure from one of these papers. This is a normal patient, healthy volunteer with the serum spiked with these drugs. And it shows that these drugs run in the same electrophoretic area, IgG and kappa. So there is ample scope for confusion. This is a multiple myeloma patient in remission. So the patient doesn't have a spike anymore. But if these drugs are present in the serum, then they do run in the same position. And this, in fact, is a multiple myeloma patient who does have a persistent M spike, IgG kappa spike. And as you can see, these drugs run in exactly the same position. So I'll talk about this, but these authors do describe this new assay called Hydra shift assay to overcome this problem, of false positives. What they do is they use this anti-daratumumab anti-sera is combined with the patient's serum during sample application. What it does is this antibody to daratumumab binds to the drug to form a complex, which is obviously bigger in size and has a higher molecular weight and a different electrophoretic mobility. And so it will run differently. It will run slower. So it migrates in the alpha region rather than the gamma region. So it will avoid interference with the patient's original M protein. I don't know how widely this is practiced, but that was a cool technique. And while I'm on this topic, I'll just say a few words about eculizumab, which is another monoclonal anti-complement 5 antibody. This antibody is not detected in the serum, but this eculizumab can actually be detected on your tissue, on immunofluorescence. It can show up and can cause false positives because it has this combined murine and human sequences, and it has two heavy chains. It has IgG2 in the hinge region and in the variable region, or sorry, constant region 1, and it has IgG4 in the constant region number 2 and 3. So, and this eculizumab will bind to wherever there is C5 in the tissue, in C3 glomerulopathy as well as in AHUS. And on your immunofluorescence staining, it will show up. And just as an example, this is another case we had. I won't go into too much detail here, but this was another patient who was literally 8 years old, and she was diagnosed with C3GN. This was her original immunofluorescence before receiving eculizumab. It's mainly C3. There is a little bit of IgG, but much fainter than C3. That's why probably she was given a diagnosis of C3GN rather than immune complex MPGN. She also had lambda dominance things and IgG3. So just shows how subjective, this same immunofluorescence pattern, but this patient was diagnosed as C3GN. She received eculizumab treatment for about 1.5 years because she didn't respond to anything else. And then the repeat biopsy, the immunofluorescence started to show this bright IgG. Instead of lambda, now we are seeing kappa. And on subtyping, it shows IgG2 and IgG4. So if you remember this eculizumab antibody, the IgG2 heavy chain and IgG4 heavy chains, they show up on your staining. So pathologists and nephrologists, they need to be aware of these false positive things. You can detect these therapeutic monoclonal antibodies in the serum also and in the tissue also. So unless you're careful, it can lead to overdiagnosis if you don't think about these things. Eculizumab can get deposited not only in the glomeruli, but in patients with thrombotic microangiopathy, they go and bind to blood vessels because that's where complement is in HUS. So it's another case we had IgG2 and IgG4 in the arterioles. Okay, so that was just a little teaching point. And then coming back to our case, as you know, daratumumab was stopped. The patient was being maintained on mycophenolate. Lo and behold, proteinuria again started to go up towards the end of 2022. It was again up to 4 grams. The patient comes back. We go for another biopsy. This is biopsy number 5. Glomeruli look similar. However, unfortunately, now they're developing periglomerular fibrosis around them. And what I mean by that is because the Bowman's capsule is becoming fibrotic, the connection with the tubule is probably getting narrow or cut off, which means it's going to affect the filtration pressures in the glomeruli. So even though the glomeruli look open, they're not sclerotic, but still they may not be functioning optimally. And now we are beginning to see zones of interstitial fibrosis and tubular atrophy. So now there is definitely chronic injury coming along. These are all small atrophic tubules, few sclerosed glomeruli, another area of fibrosis. On immunostaining, if you remember, IgG had completely disappeared in the previous biopsy, but now we are again seeing these little granules here and there. IgM, there is a little bit, not much difference though. And there's quite bright C3. It's just not going away. Kappa lambda, it didn't really show anything decisive. I mean, the kappa looks a bit brighter, but what that means, I don't know. Subtype staining did not show anything very specific. So there's mild IgG staining, strong C3 staining, not much on IgG subtypes. On electron microscopy, again, in the previous biopsy, we had started to see fewer and fewer deposits, but now again, we are seeing quite prominent electron dense deposits. This is like a huge subepithelial hump almost. And I don't think she had any bacterial infection. Viral infection could be some upper respiratory tract infection or something, which even may have triggered this. I don't know. It's hard to prove. But it's taking an upward turn again. I mean, it's not looking good. Again, we started to see endothelial tubular reticular inclusions. We had seen this in the very first biopsy in 2007, if you remember. So, to summarize, this unfortunate patient, the disease was first detected at the age of 17, technically still in the pediatric adolescent age group, in an otherwise healthy female, nothing else, no other autoimmune diathesis or anything. It was a C3 dominant GN with monoclonal IgG3 lambda staining, with low serum complements, transient nephritic factors, wavering proteinuria up and down, but normal renal function for a long time. Never really had a true detectable M protein or any autoimmune serologies or an obvious bacterial infection. She did have an episode of COVID-19 infection sometime during her course. Lack of a sustained remission with rituxan, bortezomib. She did have some remission and improving complement levels with daratumumab. But the moment daratumumab was stopped and when she was maintained on mycophenolate, deposits started to come back. So now she is still under treatment. She still comes and she has been restarted on daratumumab infusions. So we have to, it's still a work in progress. We'll see how it goes. But, and I don't want to show too much more, but just to show you, just to highlight how these cases are, how the trajectory of these diseases vary from patient to patient. Another case, this is the case I showed you with that eculizumab staining, 8-year-old girl with C3GN. She was treated with rituximab, mycophenolate steroids, and then eculizumab, but she's not showing a sustained remission on eculizumab. Even though this is a C3GN, we're giving C3 like complement blockade therapy. Still, proteinuria is coming back, and she is also now being tried on a plasma cell therapy or daratumumab. So let's see what happens in the future. These are all cases that are still active. And then there was another case which we actually published before. It was a C3GN case that also was refractory to eculizumab and rituximab, but it did show good response to the plasma cell agent bortezomib. So it just goes to show that these patients, you need to tailor the therapy for every patient depending on how the patient responds to these. Some of them may respond to complement blockade, but some actually respond better to B-cell agents. So, which begs the question, C3G and immune complex, even though our understanding has improved, we have come a long way understanding these diseases. We have this new classification now, but are they really separate disease entities, or are they just homogeneous groups or clusters along the same spectrum with varying contributions of complement-mediated injury, some degree of autoimmune injury, infection, paraproteins? Maybe that as the disease evolves, there is a resolution of the infection or the autoimmune process with the immunosuppressives that you give, and the classical pathway is shut off, but the alternative pathway activation persists. And so that IgG staining disappears, but complement staining, C3 staining persists in the biopsy. People have tried to use C4D immunofluorescence staining to help differentiate between C3G versus immune complex MPGN, but using more number of cases, it was not found to be so reproducible. So some pitfalls to begin with in this IF-based classification of MPGN are nicely described in this paper. The C3 dominance criterion was established using patients with dense deposit disease diagnosed on morphology as a reference group. It was not validated using patients who had known genetic abnormalities or dysregulation of the alternate pathway. And not only in our experience, but even in other groups have reported that 16 to 40% of patients have this shifting or changing immunofluorescence pattern between these diseases. Either from C3G, they start to look like immune complex MPGN or vice versa. So it is very important that we look at all the biopsies of the patient, not just one biopsy, because the immunofluorescence pattern may change. Even distinction between dense deposit disease and C3GN on a biopsy is not always straightforward, clear-cut. In some cases, we see a mix of both these patterns. You may have few dense deposits along the GBM, but in other areas of the biopsy, you see more immune complex type deposits, which are typical of C3GN. So there are definitely overlap cases. Even in a single family or a pedigree, some members may have C3GN pattern on the biopsy, and some may actually have dense deposit disease pattern, once again showing that there is tremendous amount of overlap between them. Complement alternative pathway dysregulation is not only seen in C3GN cases, but it has been found in cases with immune complex MPGN also. Even immune complex MPGNs do have nephritic factors and complement gene mutations. In fact, up to 50% of immune complex MPGN cases have been reported to have low C3, normal C4, which is a pattern that suggests alternative pathway activation. This is a nice paper by Iotropoulos, where they use this unsupervised hierarchical clustering their theory is, instead of classifying these diseases, it's rather better to put them into clusters, where similar diseases are put close to each other and diseases which show more dissimilarities are put in different clusters. So, you can talk a lot about this, but it would be better for you to read the paper. It clearly shows that there is a lot of overlap between these clusters. These complement genetic abnormalities can definitely overlap between these clusters. So how should these patients be managed? And I think I can open the floor for discussion, and even you whatever your perspective, you can definitely share. But I think that as the disease evolves, the patient may have the therapy may have to be directed to multiple targets rather than a single target. The autoimmune process, infection, nephrogenic plasma cell clone, and then blocking the complement, which the complement is probably the effector that causes the actual injury there. So maybe at different stages of the disease, you need to target different aspects of the disease. As far as complement blockade is concerned, most of them used up till now was C5, were directed against C5, eculizumab, and then now we have this ravulizumab, which is, I think, longer acting. Avacopan is directed against C5a receptor, and then there are several others. Eculizumab has shown dramatic response in hemolytic uremic syndrome, but not that great in C3GN. And it's possible the reason may be that it doesn't improve C3 dysregulation. It only acts against C5 and the pathway, downstream pathway, the membrane attack complex and all. But if the C3 dysregulation is the main driver of the disease, eculizumab may not address it. And so now we have newer and newer complement blocking agents that act much higher in the pathway. Iptacopan actually inhibits factor B, like formation of C3 convertase. In addition, these patients also probably need B cell therapies and plasma cell therapies, not just complement blockade, but even blocking the B cells. The daratumumab has multiple mechanisms of action and tends to develop less resistance, and it shows a good response in pre-treated and relapsed patients who have not responded to bortezomib. And B cell antibodies, the newer ones are obinutuzumab. It's a newer generation anti-CD20 antibody, which has a slightly different way of binding to anti-CD20 and has multiple mechanisms of action. So it kind of overcomes the resistance to rituximab. So just some takeaway points from this case. C3G and immune complex MPGN, these tend to be chronic, slowly progressive, but really relentless diseases with waxing and waning proteinuria, lots of ups and downs, with a lot of overlap in morphology and also the serologic findings, serum C3 and nephritic factors. Patients tend to have repeated biopsies. Some of them, I mean, not all of them are done at the same institution often. So it's very important that we go back and at least try to get the previous biopsies if possible, or the report if possible, and look at the whole picture rather than just focusing on a single snapshot biopsy, because they do tend to have these changing immunofluorescence patterns in consecutive biopsies. But the one approach for management, of course, you have to exclude all treatable causes such as obvious bacterial infection or autoimmunity or an obviously detectable plasma cell clone. If all that is excluded, then probably it's more of an idiopathic C3G or immune complex MPGN. IgG subclass staining and pronase digestion to look for mask deposits tend to be quite useful. It has a big application in the diagnosis of these diseases. Of course, we don't do subclass staining in all the biopsies, but this group of diseases definitely requires IgG subclass staining and protease digestion. And another thing to keep in mind are these therapeutic monoclonal antibodies. They can hang around in the serum and in the tissue. And so they can show up in your lab assays. They can interfere with lab assays and give rise to false positive results. And we need to avoid overdiagnosis of diseases because of these interferences. And treatment really needs to be carefully tailored from patient to patient. It's not one size fits all. Different patients may respond to different therapies. And you may also have to tailor a therapy depending on the stage of the disease, with changing targets as the disease evolves. So I think, and this is just a slide showing the investigations that are usually done for these patients. And you need an EDTA plasma cell, EDTA tubes, so you need plasma samples. And there are mainly three groups of investigations: biochemical evaluation of alternative pathway, looking for autoantibodies against these various complement regulatory proteins and autoantibodies against the C3 convertases and so on. And then, of course, genetic testing to look for genetic variants in factor H, factor I, membrane cofactor protein, thrombomodulator, and so on. But to begin with, I think serum C3, C4 levels and all these soluble MAC, B fragment, and so on. I think that's the way to handle these diseases. But still, we still have ways to go in understanding these diseases. So I think I will stop there, and would like it if you all can share your perspective or your experience with this.
Thank you, Professor Satoskar, for this highly elegant talk.
Mm-hmm.
Really interesting and
Any
full of
questions?
actions. 1 minute, please. Wissam?
Any questions? Are there any questions?
Yes, Anjali, thank you. This
Uh-huh.
was really an extremely interesting case. Amazing how it proceeded. I just wanted to ask from early on two things. First, when you said that you checked for the mutations, for all the complement factor mutations, but you didn't check for the presence of autoantibodies against any of these complement factors, just for the genetic mutations?
I think they have that whole panel, University of Iowa, that's where we send our samples, and they do have, I think they do check for factor H on antibodies and factor I, and that was negative. Their panel also is evolving. I guess at that time they had fewer tests, now they have more tests. But we never really found definite autoantibodies other than the nephritic factors. We didn't find any. They checked for them.
Okay, the second thing is the EM. I have a tendency that when we see these subepithelial humps, with the presence of subendothelial deposits, and they did look in the early biopsies a bit like really a hump, and with such a bright C3 to go more for a C3GN. But you seemed more inclined that you could have had a superimposed infection rather than this was part of the C3GN.
No, actually, infection was never considered. Means we never found any obvious infection. And the fact that this disease was coming back again and again, recurring, it was very unlikely that it was infection. Our only confusion was, well, the very first biopsy was in 2007. At that time, we didn't even have this classification of C3GN.
Yes, true.
But when she came back again in 2018 and on the around that time, somehow this PGNMID was like we were thinking of it a lot because the staining pattern, IgG and monoclonal staining. So yeah, she actually was never really treated with eculizumab for some reason. It was never
exactly. This was going to be the third question. She was always addressed as she was treated with monoclonal, rather than a C3. Although the persistent finding consistently in all her biopsies were actually the C3. Maybe because she did not have any mutations. I don't think all patients, I don't think all patients with C3, if you do not have actual, and not all mutations as well, would respond to eculizumab or be candidates for eculizumab management. But we have a lot of nephrologists, so maybe they can comment on this point.
Yeah, the first biopsy had shown a lot of IgG staining, if you remember. IgG.
Yes, I remember. And which is what we are discovering now, that these patients can start with what we would call an immune complex mediated, or even a C3 dominant GN, but an immune complex mediated, and then they shift along the way to a C3 dominant GN. Also, there seems to be, since the latest also paper or findings from Mayo, and it seems that there is it's the link between the C3 and the monoclonal gammopathies is getting stronger. But what's amazing in this case is that she's so young. I mean, this is usually a concern in patients above 50 years old, but to start with this scenario at 17, you wonder what is the real culprit here? Is it really the monoclonality or the C3?
Yeah, and I showed you that case number 2, remember, with the eculizumab staining coming up in the biopsy. That patient also had bright C3, but also had this IgG lambda, very similar to this case. But that case was labeled as C3GN, maybe because it was an 8-year-old patient, and the C3 was way like more than 2 orders of magnitude or higher or whatever. But it just tries to highlight the subjectivity that exists even in our diagnostic angle that we give it.
Okay, we have a question.
Professor Dawlat wants to comment, but she is unmuted. She is muted. Professor Dawlat, please unmute yourself. Unmute yourself. Yes.
You hear me?
Yes.
Yes, it's clear now.
All right. Thank you very much for the very rich, intense talk by Professor Satoskar. What, as a nephrologist, the two conditions, the C3GN and the PGNMID, they are very strongly overlapping. Now, how can you really pinpoint that it is this one or that one? And you spoke about tailoring of treatment. How can you tailor? What are the points that help you to tailor a treatment for one of them?
Yeah, that is not something that there's no consensus on it as yet, unfortunately. we are just learning more and more, and we're discovering more and more overlaps between the two rather than differences.
Yes. So I have to treat them both in the same way, which is the anti-B cells or anti-clone of B cells by bortezomib or bortezomib or whatever alternative. It's the same for both of them.
I think so. That is what this is coming down to. But
right.
of course, you need to first exclude any other obvious etiologies, as I said, as obvious autoimmune disease or infection or
All right.
like monoclonal gammopathy.
And do you have any explanation why the immunoglobulins are negative? In some cases, 30% of cases are negative. And for this case, she was negative in the beginning, and at some stage, her immunoglobulin serum immunoglobulin was positive, right?
The spike, you mean, the IgG kappa spike? That was because of the daratumumab.
Because of the drug. This is iatrogenic spike.
Yeah,
Like,
yeah. She never otherwise had a spike. Her bone marrow biopsy also was done and it was negative. And
so it's by exclusion. It's secondary to the drug, not to a clone, a real clone activity. And is there any place for bone marrow biopsy to see clones of the plasma cells?
yeah, I mean, it was done in such a young patient, but still it was done when she came for a second biopsy in 2013. They did do a bone marrow biopsy and ruled out any obvious clonal expansion of plasma cells at that time.
Yes, and that's why
I
they
think what
started
was interesting is that, and correct me, Anjali, if I missed something, but at the time she had the false IgG kappa spike on the electrophoresis. She did not have any monoclonal deposits in her kappa and lambda were almost more or less equal or very faint.
Well, in fact, on that biopsy, they were negative.
Yes, in this specific biopsy, yes, exactly. In this specific biopsy, they both were negative and the IgG was very weak. So this also supports the fact that this spike was actually drug-induced.
Yeah, and then it started to disappear.
Yes.
On its own.
So the way to differentiate is just to stop the drug and see what happens to the spike.
I think it disappears even when you're still on the drug.
Yeah, she was still on daratumumab.
Yeah.
They did not stop
it just takes time. Yeah.
Right.
Okay, we have some questions on the chat and we have comments from our attending professors, Professor Rad Said and Professor Faisal Shaheen. But let me start by the first question on the chat about multiple biopsies taken. Why? And for me to explain as a clinician, I feel that if the biopsy did not lead me to the clinical decision, I feel somewhat that I did an injurious, unneeded injurious procedure. And this makes me to stop before the next biopsy. If I did the second and didn't gain a therapeutic decision, I really, for me, will not take the third or with extreme caution. For this patient, I think it was 5 biopsies. And reflections on treatment, do you feel it is satisfactory, Professor Satoskar, or only from the academic side for the diagnosis?
Yeah, it is true. Ours is an academic institution that definitely influences patient management. But also, there were so many years between these biopsies. For example, the first one was 2007, then 2013 was not even done in our institution. She was last to follow up. She went somewhere else. And then she came back in 2018. So it was not like they were done in a few months or something. They were done over a long period. And this patient somehow seemed to be very, very cooperative because she herself is in a medical profession. She's a nurse, I think. And so it comes down to being in an academic institution, the understanding between the physician and the patient. And it was a period when our understanding of these diseases was in a state of flux. It's not like this was not a case of lupus where we know exactly what it is. This disease is just very enigmatic. So that is the third aspect. That is another reason why repeat biopsy. And in US, I think it is more of the nature of practice is more like dependent on investigation and documentation and the nature
of course. will not be that injurious, but for me, for me and for us at the clinicians, we are afraid of this. We look for the whole procedure. By the way, I am Yasser Abdelhamid speaking to you.
That is true.
Thank you. Thank you for your explanation. Professor Dawla, Professor Usam, can we proceed to the other questions in the chat?
Yes, of course. Please do.
From Dr. Rami Shahat, he is our coordinator today, and I would like to thank him so much for his efforts. To this specific group of diseases, can you please explain more value of IG subclass analysis and reflection on diagnosis and treatment?
As I can tell you about diagnosis, IgG subclass will show you the presence of monotypic versus polytypic heavy chain. It adds to your what you see on kappa lambda staining, you know. And then the reflection on diagnosis and management. I mean, there's nothing. I don't know if I can satisfactorily answer this question, but IgG subclass staining is more complementary to your kappa lambda staining. Sometimes, you know, kappa lambda does not directly indicate monoclonality. If there are multiple heavy chains, like if in addition to IgG, if you also have a little bit of IgA and little of IgM, then you will have some light chain with those additional heavy chains also, as a result of which you cannot definitely draw a line between the kappa and lambda. You can have both. But in addition to that, when you have IgG subclass staining, and if you see only one IgG subtype staining, it adds more support to the notion that it could be monoclonal.
Okay. Thank you for your response. We have a comment from Professor Faisal Shaheen. He is the past president of Saudi Society of Kidney Disease and Transplantation, professor of kidney transplantation nephrology in Kingdom of Saudi Arabia. Please, Professor Faisal.
Thank you, Yasser. Actually, I will continue what you said about many biopsies done, which again, either it encourage us to have again repeat the biopsy if there is no response to the treatment, or it is like you know, protocol biopsy done for such patients, like post-transplant protocol biopsy or something. Because this is what I noticed, many biopsies taking even different pathology, also a little bit different pathology and different management as well. Remove from rituximab to eculizumab to different things. So this either make us a little bit confused, either we should go in that direction or we're stuck to one diagnosis and one management. Thank you, Prof. I enjoy your talk very much.
Sure. One diagnosis, one management would definitely be a better option, provided the patient shows some response.
Yes. Really, this patient was very interesting in transformations and clinical pathological transformation all through her journey. Again, Professor Dawlat, you are unmuted. You can speak.
About post-transplant recurrence, they are in both situations. I think they are equal. Do you have any experience in such cases in your center? As you mentioned, you have a transplant center as well.
Yeah, this PGNMID definitely can recur. We have also published cases there, and other centers.
To the same extent, or they seem to be merging into each other, the two situations, the two conditions.
Yeah, I don't think we have really compared that, because as I said, these, at least the C3GN disease is pretty rare. It's not that common, fortunately. And it goes on for many years before the patient actually develops renal dysfunction. So transplant comes after that. But I don't have so much experience with C3GN, but with PGNMID in adults, yes, it definitely recurs in allograft.
All right. Thank you.
Usam, do you have a comment?
If I may comment, yes, not all the recurrence of the C3GN depends on the original mutation. So some mutations have much higher risk of recurrence post-transplant in related to the gene mutations, and others do not carry the same risk. Also,
Yeah,
C3GN is quite heterogeneous and variable. So not all the patients would progress to end stage. Again, it depends on the extent of the mutation and its type and the gene which is affected. And which factor are we talking about here?
Yeah, I can tell you what I know. I think factor H mutations definitely recur, but
Definitely, yes.
factors which are restricted to the kidney, like factor I and membrane cofactor, or maybe membrane cofactor protein, it's only present on the surface. It's like a surface molecule. So if you replace the kidney, if you put in a new kidney, it does not recur.
Exactly. And I think there is also there were new ones related to factor I as well, and they carry a better prognosis even. So the recurrence. So in these patients, really, you cannot judge on the recurrence without the genetic testing.
Yeah.
We have a question from Professor Dalia Rushdi, Professor of Nephrology, Asr Al Aini, Cairo University. He is asking two questions. Did you consider to do plasma exchange and IVIG for treatment of this lady? And the second one,
No, yeah, I will answer this question first. No, they did not consider. I'm a pathologist, actually. It's the management was being done by the nephrologist, but no, they did not do plasmapheresis or IVIG in here, because you really don't know what you are removing from the plasma, because she doesn't have a spike. Her complements are low. So even if you do plasmapheresis, there's nothing to like an endpoint or a metric or anything. We don't know what we are removing.
Yeah.
IVIG, maybe I don't know what exactly is the action of IVIG. It's like
intravenous immunoglobulin.
But I don't know what exactly it does. I don't know. It's an immunomodulator probably. So I don't know. But none of these were used in this patient up till now.
And okay. Her second question is, do you think that the development of antibodies against the monoclonal antibodies drugs is an over-treatment to the patient, and the proteinuria may be secondary to these drugs? And for me to add for this question, do you see this phenomenon many times in patients taking these drugs, or this was a rare case to see these spikes?
It's common. It's common. It happens. Yeah, no, this is not particular to this particular patient. No, as I showed you that eculizumab staining, on tissue in that C3GN, that not Mayo, Columbia has published a small series on it. So no, it happens. It's not specific to this case. The good thing is that IgG spike, it disappeared on its own without stopping the drug. That was another miracle. And it didn't get deposited in the tissue. It just remained in the serum.
Okay. Thank you. Please, and for us, Wissam, did you observe this in our patients? These spikes, when we use some cases using these drugs?
Well, we don't have a lot of experience with these patients. I don't think we widely use these drugs here.
But in
and usually cases, when they're used for, they're mainly used for myeloma patients. And then I don't know what the hematologists do. Yeah, in this case, we do not get to see the repeated spikes. Then this is the hematologist. I don't know what about there, but they definitely know about these false spikes. Yeah.
Okay, thank you for this experience exchange. And Dr. Ravi Shahat, our moderator today, wants to speak and explain his second question. Please, Ravi.
Thanks, Professor Yasser, for this opportunity to share this question.
Ravi, you have echo in your voice.
Is this better?
Please. Yes, we can't hear properly. Please adjust the microphone.
Okay, this is good.
or use headphones? I think somewhat a little bit. Okay, you can go.
Okay, okay. Just I have a question to Professor Satoskar, please. Do you think this spectrum of diseases can be in the future divided again according to this lab investigation you mentioned in the last slide? I mean, if a disease related to auto antibodies like C3 nephrotic factor, I think the disease will respond to plasma exchange and IVIG, as Dr. Adalia mentioned, but if the disease related to genetic mutation or like, CH50 or something, so it may not respond to plasma exchange. So my question is, do you think in the future it will be divided to multiple diseases based on the pathogenesis of the disease based on lab investigation we can do?
Yeah, I think, as I said, the therapies will have to be tailored according to what each patient has and how the patient is responding. Yeah, for these high C3 nephritic factors, if they persist, then yeah, plasma exchange might be an option. But I've not seen that being done very often, at least currently for these patients. Yeah, I mean, it's almost like a black hole right now. I don't.
Yes, this disease passed through many classifications, and is getting more and more new classifications. And I think in the future will maybe another values for these antibodies.
Yeah, we may continue to lump these cases together rather than classifying them and dividing them.
Yes. We have no more questions and no more comments, Professor
Oh, and
Dawlat?
one more comment. This COVID-19
Yes.
pandemic was another. It was another curse, I would say, because we have seen cases where COVID-19 infection can actually unmask or reactivate or cause a relapse of cases of diseases that are quiescent. We recently saw what did we see? Cryoglobulinemic GN relapse. 2 or 3 months after the patient had COVID-19 infection. It's very difficult to prove the causation, but this patient was treated for his Hep C. He had the previous biopsy was in 2016. His Hep C was treated with Harvoni. He also got rituximab at that time. His viral load became 0. But now after his COVID-19 infection, he again got reactivated. His rheumatoid factor went up to 1,000. Viral load is still 0, but he has huge cryoglobulin deposits in the biopsy and things like that. So this COVID-19, so maybe the B cell clones got reactivated after his COVID-19 infection. So that is another, thankfully the pandemic is gone, but that is another threat, I would say. Viral infection, it can reactivate diseases, these kind of diseases, these immunologic type of diseases.
You answered my question, but let me stress on this, on your answer. You find the relation between COVID-19 and these pathological changes is not a casual relation, established relation for the presence of the virus and direct causation of the pathology, huh?
Reactivation, yeah, reactivation of underlying pathology.
Was not a casual relationship, a sure relationship for the virus, for the new virus.
Yeah, I mean, that's what I'm saying. The virus, the immune response to the virus can be detrimental in patients who have these kind of diseases. They can get reactivated. That's what I'm saying. Okay.
Thank you very much.
Sure.
Professor Dawlat, we have no more questions on the chat. And I think Wissam is unmuted. Please is muted. Unmute yourself, please, Wissam.
I just want to mention that they are two different diseases and two different etiologies. C3GN is due to the alternative complement pathway problems, while the PGNMID is due to monoclonal antibody deposition. So they are not similar they might be similar in the presentation or the pathology, but they are completely different etiologies.
That is true. But the problem is monoclonal proteins, they can behave like nephritic factors. That is the theory right now. They can act as C3 convertase stabilizers. that's where
the-
the cross connection happens between these diseases.
Okay.
We have one question.
Yes, yes, sir. Do you have something to add?
I think we have no more questions, so we can close the session.
Sure,
Okay.
thank
Yes,
you.
sir. What do you think?
Thanks once again for this opportunity. And if you liked the presentation and if you want to do some exchange talks or something in the future, please let me know, because there are a few people here. Our group is very strong with lupus, ANCA. There are several people working on FSGS. So I'm sure some of the people would like to present. Some of them also can speak Arabic, they told me. So if you're interested, you'll definitely let me know. Like we can arrange.
Thank you very much. They sound very attractive subjects. Maybe less intense than what we heard today. Today is
Yeah.
very rich and intense. Yes, and they are just classical and not new to us. This one is new to us. That's why maybe it's a little bit confusing.
Yeah, definitely. It's new to
Oh.
us also.
Yeah, I think I think this case is new to everybody. Anjali, really, this was amazing, very interesting. You have went through it very nicely, and yes, we definitely this was as you mentioned, and I'm stressing that Professor Satoskar and myself were trying to establish some form of collaboration between our institutions, and we have agreed that one of the best ways to start this collaborations is through the exchange of these talks and discussions via scientific meetings. And Professor Satoskar have gladly accepted to be our guest tonight, although it's the mid of her working day. So thank you very much, Anjali, for your time and for your presence. And we definitely are looking forward to have more sessions regarding other topics. Dr. Dawlat, I don't know what happened to Yasser.
Yes, I thank you very much for this very rich talk, and we are waiting for new meetings. Inshallah.
Definitely.
Yeah.
All right. Good night and Shabbat
Good
khair.
night.
Good night.
نشوفكم على خير. Thank you. Good
Bye.
night, everyone, and thank you everybody for the attendance, and see you soon, inshallah.
Inshallah.
Inshallah. مع السلامة.
سامعين حضرتك؟ الصوت تقريبا في مشكلة عند حضرتك. الصوت خالص وصل لنا من حضرتك. مش مسموع برضه.
سامعني يا رامي؟
سامع حضرتك دكتورة دولت، لكن